in just a minute or two once folks are set up. Feel free to turn on your cameras if you want, kind of give us some semblance of intimacy or community here, albeit over Zoom. Love to see your faces, and thanks for showing up. All right. Well, we'll get started here just because we're already about 5 or 6 minutes after. Appreciate y'all for coming again. My name is Rob Palmer. I'm a medical student at Yale. I've been involved in this group, the Yale Psychedelic Science Group, for a few years now. And during the pandemic, we've been doing these virtual Zoom meetings instead of our in-person meetings. And it's, as I was saying earlier to some folks, it's sort of been a blessing in disguise because we get to have people from all over the country and all over the world who normally wouldn't be able to stop by New Haven, Connecticut on a moment's notice on a Wednesday evening. And today is one of those instances where we get to have some people from California doing some great research and work get to present on that to us. So it's my great privilege and delight to introduce the presenters tonight. We have Dr. Cole Marta, Dr. Michael Burke, and Dr. Joseph McCowan. They'll be presenting a talk entitled MDMA-Assisted Psychotherapy for PTSD, which will delve into the history of MDMA, why it seems to be effective for PTSD, the data on its safety and efficacy, and an overview of the therapeutic principles of MDMA-assisted psychotherapy. To give a brief introduction for each of the speakers, Dr. Cole Marta is a private practice psychiatrist who specializes in using ketamine for treatment-resistant depression. He's also the principal investigator at the Los Angeles site of the MAPS Phase 2 and Phase 3 trials for MDMA-assisted psychotherapy for PTSD. And he has previously published peer-reviewed articles and book chapters on psychedelics such as ketamine, ibogaine, and MDMA. We also have Dr. Michael Burke, who is a private practice psychiatrist working on the MAPS Phase 3 clinical trial of MDMA-assisted psychotherapy for PTSD. He also provides ketamine-assisted psychotherapy for depression and has completed a fellowship in addiction medicine. And last but not least, Dr. Joseph McCowan is a licensed clinical psychologist and psychotherapist working as a co-therapist in the MAPS-sponsored Phase 3 clinical trials of MDMA-assisted psychotherapy for PTSD. Dr. McCowan's work has focused on the healing benefits of psychedelics for communities of color and underserved communities, including people with housing instability. So without further delay, I want to give the presenters the floor. Please save your questions and comments until the end of the presentation when we'll have a Q&A session, and we'll explain kind of the rules of the road for that when we get there. So please join me in giving a Zoom welcome round of applause, expressions of appreciation, gratitude for these folks for coming to present to us. So thank you very much.
All right, thanks, Rob. Yeah, and thank you guys so much for having us and for joining. It's always great to connect with people who, have a similar interest in these areas. And before I get going, so I'm going to start things off. I don't know, Joseph, was there anything else that you wanted to add right now?
Just, it's great to be here, you all, and to share this work that we do in the therapeutic modality and connect with you all. And thank you, William and Rob, for the space.
All right, so I'm going to try to share my screen. All right. And yes, if anybody has any questions later, wants to reach out, that's my email address. Rob has my contact info. There we go. So, only disclosure I have is I receive income from New School Research, which runs the site here in Los Angeles for the Phase 3 trial, and they receive funding from the sponsor, MAPS, which we'll talk about, or I guess will come up at various points during the talk. And so I'm going to get into some of the history of MDMA, its effects, side effects, safety profile, and why it might be effective for PTSD, and then at the end get into some of the data and the clinical trial design. And then Joseph is going to come on and talk about the the therapeutic principles and what the therapy looks like. So, trying to figure out where to put you guys. Okay. So MDMA was first synthesized by a German pharmaceutical company called Merck back in 1912. And it was synthesized as one of the molecules on a way to evade a competitor's patent, and all the different chemicals along that pathway were all patented. And as the patent was about to expire, they did some studies on animals and didn't notice anything noteworthy. And it was kind of shelved. Nothing happened to it until in 1953, the U.S. Army Chemical Warfare Service tried it out as one of the different mind control drugs, didn't notice anything interesting there, and kind of shelved it. And then kind of next appeared in 1965 when Sasha Shulgin, who was a psychedelic chemist, independently rediscovered it. He was trying to make a derivative of mescaline because that was something that he'd had a positive experience with. And both mescaline and MDMA are both phenethylamines. And so the way that he would work is would create a new compound. He would try it in kind of escalating doses. Then his wife would try it. And if they thought it was interesting enough, then they had what they called the group of 12 who they would give it to. And if they thought it was worthwhile, then they had therapists who at that time in the 1960s used facilitated therapies with other compounds like LSD. And they found it to be useful. And then it was kind of brought in that community. And in the 1970s and early 1980s was used a lot with couples therapy. It was known to be effective for, also found to be effective for trauma. And also in probably the 1980s, maybe late 70s, it started to be used as a club drug. The DEA found out about it, made it Schedule I in 1985. And so then Rick Doblin, who later founded MAPS the next year, consulted with the FDA, had a kilogram of it made that eventually was used in their phase 1 and phase 2 studies, and requested, or I guess appealed the decision, and actually was granted hearing with the DEA administrative law judge. Several psychiatrists testified at this hearing, and the law judge actually ruled that it should be Schedule III based on these benefits. But the DEA had the authority to overrule that decision, which they did. It was put on Schedule I. And then in 1986, Rick Doblin founded MAPS with essentially the goal of legalizing MDMA through the medical route. So then there were 5 different proposals that were rejected by the FDA between 1986 and 1992. Finally, in 1992, the FDA approved the first phase 1 study, and that's Charles Grobe, who was the principal investigator. He's now at Harbor UCLA. And those studies went well, showed that it was safe. And in 2001, the FDA approved the first phase 1 study, but it took another 3 years until the DEA approved the first, I think I said phase 1, I meant phase 2 study. And then in 2004, the DEA approved the first phase 2 study. And between 2004 and 2018, there were then 6 phase 2 double-blind randomized controlled trials. 2017, it was granted breakthrough status by the FDA, and then in late 2018, the first phase 3 trial was started. And where we are now is actually, we're kind of in between the 2 phase 3 studies, or actually the second phase 3 study has started. The first ended this, I guess, in the middle of COVID. So there is some literature about the therapeutic use of MDMA while it was legal before it was scheduled. And there was an estimated 500,000 doses given legally by therapists before it was made Schedule I. Okay, so yeah, so getting into the pharmacokinetics, the molecule is 3,4-methylene dioxymethamphetamine. The generic name is methamphetamine. It does have one active metabolite, which is MDA, which is I guess, described as somewhere on the spectrum between MDMA and LSD, kind of has properties of both, and was actually another compound that Sasha Shulgin had discovered. It's known to be a 2D6 inhibitor for up to 10 days. It's primarily metabolized by 2D6, 1A2, and 3A4. Half-life 7 to 9 hours. Onset of effects are typically 30 to 60 minutes after the medication is taken, and then the peak starts at about 75 to 120 minutes. The way the trial is designed, people have the option for a supplemental half dose at 90 minutes into the session. And with this, the duration of the session is about 6 to 8 hours. And we'll get a little bit more into the dosing later on, but it starts off at 80 milligrams with a 40 milligram follow-up, supplemental optional half dose. And then the second and third sessions, they have the option for 80 milligrams or 120 milligrams. And again, a little bit later, we'll go through what the structure of the treatment looks like. So as far as its mechanism of action, it works in a few different ways. It's a VMAT2 transporter inhibitor in the presynaptic terminal. So it prevents the monoamines from being sequestered in vesicles. And with this increase in serotonin, norepinephrine, and dopamine in the terminal, the uptake transporters are actually reversed, and this leads to an increase of the monoamines in the synaptic space. So it leads to increase, and it's also a triple monoamine reuptake inhibitor in addition to the increased release. So the primary, I guess, monoamines are serotonin and norepinephrine, with also some increase in dopamine, and it leads to increase in some hormones as well. So oxytocin's increased. We know from animal and human studies that this is something that helps facilitate pair bonding. And there's also an increase in cortisol levels, which leads to an increase in emotional arousal. We know it's an important part of fear extinction, and it's something that's deficient and shown to not, I guess, increase under stress in people with PTSD. And there's been studies that show that this is likely an important part of the treatment, since when cortisol was not increased, people didn't have an improvement in mood after taking MDMA. And a couple other hormones are ADH is released, and then prolactin is also released. And ADH we'll talk a little bit about later when we get into side effects. So the study sponsor MAPS classifies MDMA as an entactogen, which they define as a substance that produces change in mood and social interaction, as well as feelings of interpersonal closeness and changes in perception. And so this covers it pretty well, I would say. People report enhanced feelings of love, empathy, feeling more connected with others, and an increased sense of interpersonal trust. And all of these have been seen objectively on some studies as well. People showing increased measures of compassion and pro-social communication and behaviors, as well as being quicker to detect happy faces and less able to detect negative facial expressions. As people also report increased feelings of well-being, euphoria, extroversion, have reduced feelings of fear, and kind of overall are in like a heightened state of consciousness where maybe their kind of typical thought patterns are interrupted a little bit to have these other effects, and oftentimes come away with new insights into themselves, and are able with seeing themselves in a different way, oftentimes come away with more compassionate view with regard to themselves and kind of how they got to where they're at as far as certain maybe behaviors and things like that. So getting into safety, the study brochure from MAPS says that the LD50 is likely between 10 to 20 mg per kg. And in animals, this can vary really widely. But in animals that are kind of get closer to humans, it goes from a high LD50 to more in the teens and 20s range. So primary thing that we worry about, oh, and I guess there's one more piece on this, is that, so the typical dosage that people receive in the study is from 1 to 4 mg per kg. and with 4 being the very highest, due to, I guess, weight restrictions. So primary concern with, with safety is your cardiac related, and it can be thought of as something that has stimulant effects. So increase in pulse, blood pressure, peaks at 1 to 2 hours, typically resolves by 4 to 5 hours. And so part of the screening process is we want to, screen out people with significant cardiac risk factors or history of arrhythmia. So things like uncontrolled hypertension, chronic heart failure, hypokalemia, elevated QTC, or if they have a history of cerebrovascular disease. Hyperthermia is another, I guess, phenomenon that's been documented. And the previous investigators' brochure mentioned that there's an average of 0.6 degrees Celsius increase in core body temperature in the studies. The more recent one just used the statistic that there's been an elevation of 1 degree Celsius in 44% of MDMA participants versus 20% in placebo. And the highest they've had in any of the phase 1, 2, or 3 studies is 38.7 degrees Celsius. And, so within the controlled, clinical therapy settings isn't much of a concern, but you could see how if you use recreationally, in a club or, festival, rave, something like that, where people are dancing and they're surrounded by other people that are dancing, how, that could become an issue. So hyponatremia is another concern, and, the amount of fluids that they can take in a session is limited, although it's a pretty high limit. And this is at least due in part to the increase in vasopressin or ADH that comes with MDMA. People can have hepatotoxicity that's secondary to if they become hyperthermic, and there is risk of a serotonin syndrome. So far in all of the phase 1, 2, and 3 studies, there's only been one event that was classified as a serious adverse reaction, and that was in a patient who had extraventricular systoles at baseline, who had an increase in these, during a therapy session, and they were hospitalized for precaution, but no interventions needed, and and no harm to that participant. So overall, the risk for serious adverse events considered to be very low. It's important to factor in recreational morbidity and mortality accounts of MDMA, but also keeping in mind that this is in the setting of people who were polydrug users and who were taking ecstasy tablets that oftentimes have other substances in them. Methamphetamine's a frequent one, also cathinones and things like that. And there's been some studies that show that actually a lot of ecstasy tablets don't have any MDMA in it. At the same time, people are often taking multiple tablets in a night. So if they are taking one that has MDMA in it, it can be at a much higher dose than they would receive in the clinical trial. And just to kind of put this in perspective, it was estimated to be taken 20 million times a year, and all of the, I guess, morbidity reports that have been published account for 279 deaths over a 22-year period. Not that they would necessarily, catch all of them, but relative to the, amount that it's taken, and even in these uncontrolled settings and people who don't have, physical exam, still, safety is a concern, but, there was, I think, a time where it was an even higher concern than currently. So adverse effects, you can see the list on the left-hand column there, and it kind of reads like what you'd expect from something that has psychostimulant properties and something that causes people, with a history of trauma to relive their trauma. As far as long-term risks, they appear to be minimal based on current data. There's been neurocognitive tests done on phase 2 participants that show no changes after treatment. There's been a PET scan study taking a look at serotonin transporter binding before and after MDMA use, before and then 4 weeks after MDMA use, and found no differences there. There are well-documented neurotoxic effects in animal studies. given at much higher doses than in clinical trials. And there was one retracted study in the magazine Science from 2002 where they said that MDMA had dopamine toxicity based on studies with rats, but it turned out that they'd actually given the rats methamphetamine. And so they later found this out and had to retract the study, but it was still something that was incorporated into the safety literature. And there are retrospective studies of ecstasy users that show that people that are high dose users and use frequently can have neurocognitive side effects. So this is an important factor, and one of the reasons we tell it is something that we inform the participants about, and that there are these risks if they are taking it out of these controlled settings. But at the same time, this is people with polydrug users taking ecstasy with unknown contents. So looking at the abuse potential, animal studies and human studies have shown that it has lower abuse potential than psychostimulants in its proposed Schedule 3. Looking at the pooled phase 2 data, there's so far been no treatment discontinuation due to drug seeking or drug craving. Out of the 92 participants who responded to, or I guess who were available for follow-up, 8 out of these 92 reported using MDMA after completion of the study, and said that they were essentially trying to recreate the therapeutic setting that they had in the study. And most of them said that they didn't have any interest in trying to do that again. Notably, 6 out of these 8 had used ecstasy prior to the study, and that's relative to 30% of all participants had tried ecstasy at some point, at least 6 months prior to enrollment. And urine drug screens were negative throughout the study for MDMA use. So I think a really important thing to understand with this therapy and with MDMA as well is that I think the common conception is that people are going to take MDMA, you're going to have this euphoric and connecting type of experience. But for people with trauma history, it can actually be really challenging. And hopefully maybe someday some of you will be able to either participate in this or see videos. But when you watch the videos, you see this 40-year-old on the couch who's really, you see them kind of they look like a 4-year-old or 5-year-old kind of reliving their trauma with the kind of their mannerisms and how they speak. So they can be really difficult experiences. And I think this kind of gives an indication of why taking it in recreational settings can be risky, because things like this can come up that the person's not prepared for and the people that are around them aren't prepared for, which can be harmful. So just a little bit on available treatments for PTSD and why there's the need to look for other treatments. There's 2 FDA approved medications for PTSD, Zoloft and Paxil, and just about every class of medication is used off-label for people with PTSD, and with oftentimes with some degree of benefit. And for some people, these medications can make a big difference. But there's a lot of people who still, even after taking medications, several different combinations of medications, don't get the relief that they're looking for, in order to live the type of life that they want to live or live in a way that they want to live. And I'm sure we all know that, the side effects from these medications can be significant. Psychotherapies are, first line for PTSD, and there's some different options: prolonged exposure, cognitive processing, EMDR, sensory motor, somatic experiencing, internal family systems therapy, acceptance and commitment therapy have all shown benefit. And some of these studies show really good results in these controlled settings, but when you look at naturalistic studies, you can see kind of the difficulty that therapists out in in the community, the difficulties that they run into, and the difficulty for the patients entering the therapy. Looking at the VA studies, 2 to 30%, 2 to 32% of participants who enter, who seek trauma therapy and begin it, only 2 to 32% end up finishing what they would call an adequate course of therapy, which most studies say is around, defined as 8 sessions. And, oftentimes at the VA, the full course would be 12 sessions, but their cutoff was 8 sessions. And even for people who complete it, 60 to 72% of veterans still meet PTSD criteria after a course of prolonged exposure or cognitive processing therapy. And a big part of the reason for this is just that trauma therapy is really difficult to tolerate, and especially early on in therapy. Difficult to keep patients kind of in that optimal arousal zone, with kind of keeping them from either going into fight or flight or shutting down. And traumatic memory by itself is implicit and fragmented, and a lot of times experienced as sensations experienced viscerally. And a lot of the more kind of top-down cognitive therapies don't necessarily target these symptoms very well. So, and then attachment and transference issues are a big part of trauma therapy, and at the same time it can be a challenge to work through. So why MDMA for PTSD? So we know that it decreases fear and defensiveness and actually allows for this processing of traumatic memories within the optimal arousal zone. And it does so without clouding the sensorium. So it's not like people are, intoxicated and disconnected from their experience or from their memories, but they actually kind of have this, period of heightened sensory perceptions. And, typically it's going to be things that they kind of, remember and, are present to process. It allows for increased access to past memories, including these, more visceral somatic memories. Provides a period of time where they have, these increased emotions, increased positive emotions towards oneself, and come away with a better understanding of themselves, come away with a better sense of self-compassion, and with increased sense of safety and trust. They're more apt to have a secure relationship with therapists. And we know that one of the predictive factors of successful therapy is the relationship between the patient and the clinician. So kind of a combination of these is we think part of it. So another way to look at it is taking a look at the neurocircuitry, and I think doing so without getting too reductionistic. So, and this isn't an exhaustive list either, but from what we know from fMRI studies, there's increased activity of the amygdala in people with PTSD, and we know this is the fear center that generates the fight or flight response. There's decreased activity in the hippocampus, which is important for organizing, sequencing, and contextualizing events, and kind of bringing the memory from implicit to more narrative. And also decreased activity of the medial prefrontal cortex. And so this is kind of part of the reason, why when, traumatic memory is happening, medial prefrontal cortex shuts down, and it feels like all these things are happening right now, you're in danger right now. And when the medial prefrontal cortex is able to come back online, people are more kind of attuned, more aware, and kind of have a deep sense, or know in a deep way that these are events from the past. And so MDMA, we know from fMRI imaging that it provides this window of time where all of these changes are reversed. So it kind of creates this period of time where these memories can be re-encoded in a way. So the phase 3 study is divided into two 100 participant studies. The first one, again, ended in the spring, and they ended up stopping at 91 participants, due to COVID. And they also had interim analysis done that looked favorable. So I was listening to a podcast with Rick Dublin, who said that they kind of took, calculated risk with the thought that, increasing the number of participants always, increasing the power would always, help to show a difference from placebo. But they felt pretty confident that they could stop it at 91 people. And I think they're going to be releasing this data fairly soon. So I guess we'll get to find out. And then the second phase 3 study has started, and that'll be with 100 participants. There's going to be one 70 participant study with the European Medicine Agency, and they're going to be able to piggyback on the rest of the US data for that. So it's MDMA versus placebo. There were some phase 2 studies done with an active placebo of lower doses of MDMA, but they realized that the lower dose, it was actually, they thought caused some harm, and that going with the placebo would be better, with an inactive placebo would be better. The therapy set up to be done with a male-female co-therapy team. And this is done for a couple of reasons. One, having two therapists in the room kind of adds an extra sense of safety for the participant. Having a male and a female kind of lends for different transference types of reactions. And then having two therapists just also, allows one therapist at a time to take breaks, kind of, if needed and as needed throughout the 8-hour therapy session. So as far as the structure of the course of treatment, so after a participant has been screened and been enrolled and meets all the criteria, there's 3 prep sessions done with the male-female co-therapy team. They're 90 minutes long, spaced out roughly a week apart, leading up to the first MDMA session. So these are 8-hour therapy sessions, and the first one has a dose of 80 milligrams with the option for a supplemental half dose of 40 milligrams at 90 minutes into the session. And we check vital signs at that time to make sure they're in safe parameters to give that dose, and then it's a decision that the participant makes along with the therapists. So then the day after that is the first of 3 90-minute integration sessions. So it's the morning after the first one, and then there's 2 more 90-minute integration sessions over the next 3 to 5 weeks before the next MDMA session. And so the second session is the same as the first, except there's the option for dosing at 80 milligrams or 120 milligrams, followed by the supplemental optional half dose. Then 3 more integration sessions, another MDMA session a month later, 3 more integration sessions after that, and then the primary outcome is measured at 2 months. So to orient you guys to this slide, looking at the graph, on the x-axis from left to right, you can see the number of experimental sessions with baseline and then 2 and 3 experimental sessions. And on the y-axis is decrease in CAPS-4 score. And so the reason it was done with both 2 and 3 is that the phase 2 studies were a mix of 2 versus 3 MDMA sessions. So you can see that the group that got the MDMA had a statistically significant decrease in score relative to the placebo group with a large effect size, Cohen's d of 0.8. And you can see that's a big drop in the CAPS of 32.4. The placebo group did have a significant decrease relative to baseline, which gives some indication that just the therapy itself is beneficial. And then you can see with the third session, the scores continue to drop. And interestingly, they did a survey of participants after the course of therapy and asked if they thought another MDMA session would be effective. And 94% actually said that they thought another session would be effective. So it'll be interesting to see what this turns into after after hopeful approval. But you can see that not only were these pretty substantial gains, but this was a population that was chronic treatment-resistant PTSD. So average duration of PTSD was 17 years. Average baseline CAPS score was in the 80s, indicating very severe PTSD. And so after just 2 sessions, 53% of participants no longer met criteria for PTSD relative to 19% of the control group. And we know now from long-term data that not only are the gains in or improvements maintained at 12 months, but they actually continue to increase. And that's a statistically significant difference with a Cohen's d of 0.23, which is a small effect size, but You can see also at 12 months, more people no longer met criteria for PTSD. So at the end of the study, 56% no longer met criteria for PTSD versus at 12 months, this increased to 67%. And there has been one longer term follow-up study, which was done with the first phase 2 study. And the follow-up was between 14 to 74 months after the treatment. On average, it was 45 months. And so you can see at the bottom, the mean CAPS score at the end of the study was 24.6. And then at long-term follow-up, it actually decreased a little bit. I don't think it was a significant difference, but was down to 23.7. And this is from a baseline CAPS of 79.4. So I'm going to turn it over to Joseph.
Thank you, Mike.
Yeah, I'll figure out. So I need to pass this over to you, or can you?
I can. I'm going to go ahead and share mine. 1 second. Oh, you have to end yours. Okay. 1 second, y'all. I know you see a blank screen. Hold on. Okay, do you all see this?
Yeah.
Okay. So we're going to be looking at the principles of the therapy, which will follow with a review of the prep sessions, looking at the medicine sessions, also known as the MDMA sessions or experimental sessions. And we'll wrap up looking at the integration sessions, basically looking at what the therapists are attending to and the ways in which therapists are supporting the participant through the process. But first, we'll begin looking at the principles of therapy. These are some of the core principles of the therapeutic method and model. Really beginning, just recognizing safety and support are such a critical component of this model towards creating a setting in which an individual with a history of trauma or PTSD in the situation might, in safe and supportive settings, if individual can begin to have a corrective emotional experience. So we're going to go over the therapeutic alliance, that relationship, and why trust and an empathic presence are so important. We're going to be looking at working with the inner healing intelligence, and we'll go over what that is. This therapy is very inner directive, and so we'll talk a bit about that. And also maintaining beginner's mind, we'll explore that as well. Trusting the process, working with somatic manifestations, also working with and being with multiplicity of the psyche, and working with non-ordinary states of consciousness. So beginning with the therapeutic alliance and maintaining an empathic presence. Note, having an empathic and supportive presence and maintaining a non-judgmental and compassionate stance helps facilitate the participant's experience. Often we're just following the participant's process rather than engaging in any way that might interfere with that. It really is their space and their opportunity to connect and heal in ways that allow for their inner healing intelligence really to do the work. And we're using invitation rather than direction. So we're going to be inviting the participant to connect with their inner healer and to go inside rather than using any sort of communication that might be too directive. And so there's also, reflective listening and paraphrasing to encourage reflection and to allow for that space for a person to have their experience. And we're essentially bearing witness, being present with the participant. And silence is not passive, right? Often therapists familiar with other therapeutic orientations or modalities might be drawn to fill space with words, but silence is extremely powerful in this modality to allow the participants' process to unfold. So there's very cautious about using interpretations, and there's minimal use of that, and will only self-disclose when appropriate or necessary. But it's really creating space and allowing for the participants' process. So a concept of the inner healing intelligence that, that is very similar to a concept shared by Carl Jung, Stan Grof, Richard Swartz. Those are, I'm sure you guys are all familiar, IFS, transpersonal psychology, and analytical and depth psychology. So we all have an innate inner wisdom that guides us towards healing and wholeness. Often we use the metaphor of removing if we were to remove an object from a laceration, it isn't, there was something there interfering with the healing process that has been removed. So the conditions for healing now are there, right? And so, but the body does the healing. Therapists are not doing the healing. Doctor is not doing the healing, right? Or in this case, it would be the doctor. So the body has this natural tendency towards healing. And we recognize that to also be true for the psyche. So in this study, the idea is that if the space and the conditions are created for healing to unfold, healing will naturally happen. And it's really just about providing that space and those conditions. Because the participant is the source of their own healing. And we really trust that. So ultimately, throughout the process, the participant will begin to develop a closer relationship with their inner wisdom and build a greater capacity to live a healthful life, which often they carry with them, both through the process and beyond the process. And so we're demonstrating trust and respect for their inner healing intelligence, which often catalyzes a deepening of their inner resources. And this is a powerful concept towards helping the participant connect with themselves, reorient where they're looking for healing, and help build that connection to internal resources. So this is often called a non-directive or interdirected approach to therapy. And so as therapists, we'll often oscillate between being compassionate witnesses, as well as facilitating this inner direction to support the participant's process. And, so often we're, sometimes there's a lot of, conversation, or that, not often, but it will emerge. And if that's going on, we'll kind of redirect towards checking in with themselves. Even after, but if there is long periods of silence, such as after 45 or minutes to an hour, we will check in with the participant to see how they're doing, but not to interfere with their process, just to, remind them that they're there and supportive, and if there is anything that they want to bring up, they can. If the participant is ever feeling stuck, we encourage them to be curious about that and really experience that sensation. You're like, where are you feeling it? How is it? Really kind of encourage like welcoming that and breathing into it. So there's a concept of a beginner's mind, which is really a crucial component towards that empathic presence. What it is, it's dropping our expectations and preconceived ideas about anything, and looking at things through an open mind, or with an open mind and fresh eyes, just like a beginner, essentially. And it's being present with a high degree of curiosity and wonder, much like a child. So we're maintaining a stance of not knowing what the participant's process will be and being very careful not to try to fit the participant's process into our theoretical frameworks. And we actually don't know, especially in non-ordinary states of consciousness, what a participant is experiencing at any given time. And having a beginner's mind really allows for that space and that opportunity for the experience to unfold. Because, for example, tears could be sadness or joy, laughter. It's not always certain what, it could be many things, but it's not always what we believe it to be. So it's important that as therapists, we're able to recognize that we don't always have the answers. This was communicated, or just to look at a quote from Stan Groff. A student asked him how he would approach someone who seemed to be manipulating rather than having a genuine, spontaneous process. This question could have elicited a lengthy and erudite discussion of psychodynamics, of which Stan was certainly capable after many years of psychoanalytic training earlier in his career. But Stan responded with this statement: "In that situation, I prefer to believe something is happening that I do not understand." And this is so true. We're often, especially in this work, we can, the process is unfolding in a way that we might not be familiar with. And even if we're familiar with so much, it might be, we can still, it's still important to bring a degree of beginner's mind to the process. Also hugely important is trusting the process. For the therapist and the participant, trusting the process is key. Things will unfold how they are supposed to. And that often doesn't follow the course that we might expect or that the participant might expect. Often we believe that whatever arises and comes up does so for healing. And so both with MDMA and with the inner healing intelligence, experiences will unfold like they're supposed to. And we encourage the participant to welcome these emotions, memories, or sensations, and trust that whatever is arriving is doing so for healing. And so we're also encouraging the participant to surrender the process and not get ahead of the medicine to direct or control that experience. Many folks doing this work, not myself, but others, have a lot of training and experience with working with somatic manifestations. But regardless of our training, it's hugely important that we're aware of how trauma shows up in the body and the way our bodies or how we store traumatic memories. Mike was referring to amygdala activity and hippocampal activity earlier. And traumatic memories are often stored as implicit memory while amygdala activity is heightened in high stress situations or when folks experienced their trauma. And so, our emotional memories are often stored in the form of physical and bodily sensations. So in many ways, our implicit memory is essential in survival as it enables an instant response to danger. So from an evolutionary or adaptive perspective, we can see how our brains and our bodies have developed in this way, right? It helps us remain safe in many situations. But it also, can be, this is information that's stored that's difficult to recall, right? It's stored in outside of our, or it's stored in our emotional center. So furthering our working with somatic manifestations. There's a good degree of psychoeducation in prep sessions around some of the ways that the therapist might support the participant through touch and such. And during the session, the therapist might invite the participant to check in what they're feeling in their body. And if experiencing tension, you can ask the participant to really bring awareness to the sensations and trust that their body's innate ability to process and express that, even suggesting breathing into or around that tension or that anxiety. And really, encouraging the participant to do or feel or express themselves in any way that can allow them to move through that or release that tension. And even inviting self-touch, like an encouragement of a placement on their chest or abdomen. During the prep sessions, there's also an conversation about the physical touch. It's important that there's consent and agreements around these things. And like I shared earlier, some therapists might have more training than others, whether it's Hakomi or somatic experiencing, and maybe more comfortable than other therapists, like engaging in any sort of applied pressure or focused body work. And, but that's completely all right if has been the consent and the conversation, and that's what the participant is desiring in that instance in the session, as well as if the therapist is comfortable doing so. And pillows, blankets, or weights might be used toward that focused body work. And often it's seen as unethical to withhold that touch, as a supportive touch can help provide that corrective emotional experience in certain situations for the participant. When in trauma work, or just in therapy in general, we're going to be mindful of working with multiplicity of the psyche. If you all are familiar with internal family systems and other orientations that consider parts, our parts are present in all of us, but can be especially pronounced in trauma. And so in internal family systems, each part is considered to be distinct mental systems with its own history, ability, needs, and worldview, and might serve different roles towards. And so, when functioning well, we might shift fluidly between parts, and when stuck, we may over-identify with certain parts. And we can see that sometimes emerge in sessions. And so in non-ordinary states of consciousness or with MDMA, we might see that arise, and we're very much going to not pathologize this and just welcome it and allow for the participant really to share and be really explore any sort of connection to those parts to help them get acquainted with and learn about the parts. And really kind of rolling with the process of like beginner's mind and being curious about these parts and exploring them, like what role do they serve and what's their history. Underneath all of the parts is an undamaged essence that is confident, curious, and calm. And but when there's trauma, because to protect that essence, right, protective parts may become more active. Participants often dislike parts that are angry, destructive, or critical. And vulnerable parts are often hidden. And the goal of internal family systems is to really get to know these parts and their roles, so all are welcome. And so questions might be asked during the therapy by therapists, when there's an emergence of these parts, how old is that part? What is it protecting? How has it helped you survive? How do you feel towards this part? What would happen if you asked that part to take a step back? And so not only does questioning help to understand the parts and see the roles it has served, but in a way, this curiosity and exploration can bring increased compassion for each part, which can lead to just greater self-compassion as they accept the various parts as part of their whole. An example of this, which actually comes from our manual, during a prep session, a combat veteran participant struggling with outbursts of rage since returning from Iraq stated, "I feel like there's a monster in my chest trying to come out, and I've got my hands around its neck trying to strangle it." Therapist responded, "You may find as we go along in this process that it's more of a matter of getting to know this part of yourself and having a different relationship with it rather than having to strangle or get rid of it." Now, no more was said about this until during one of the experimental sessions or MDMA sessions. After a long period of inner focus, participant returned to this. "I just had an amazing experience. There was a campfire with 3 figures around it, a wise old man, a little boy, and a warrior. It wasn't a monster after all. It was the warrior part of me. These are all valued parts of me. And they're sitting around the campfire in council." So in many ways, for this participant, the invitation to be curious about this part, about the parts of himself, potentially initiated the participant's own process and then showed up in the MDMA session in this way. Transpersonal experiences. So again, we don't always know, right? It's important to have beginner's mind about what's coming up because our participants might have experiences that transcend Western ideas or our own ideas about consciousness and relationship to the body. And this may include experiences of reliving biological birth or past life experiences or interactions with ancestors or deceased friends or family, feelings of oneness, or a connection with self, experience beyond one's usual sense of self, like depersonalization or derealization, and a variety of experiences. You know, this list is not exhaustive. So therapists are not required to have specific beliefs of meaning, but are asked to accept them as real and important aspects of the participant's experience. And it's essential, you know, to not pathologize these experiences, and because it's really an important part of a participant's healing process. We're going to be looking at, I know we're, we're looking at prep sessions. So these are going to be 90-minute sessions, 3 of them, as Mike shared, leading into the MDMA sessions and the integration sessions. And so the prep sessions are going to help develop the therapeutic alliance and orientation to the setting, you know, review of the procedures of the MDMA sessions, establishment of safety, reviewing the effects, possible experiences during the MDMA session. We'll introduce the concept of the inner healing intelligence, explore the participants' inner resources that they're currently using and working with. It's really important for the therapist to know that and help the participant connect to that. We'll allow for time to teach and review like mindfulness and stress reduction techniques, such as diaphragmatic breathing. We'll explore and discuss the therapeutic touch and help explore their support system. And we'll orient to the integration sessions and discuss even an option of bringing in an object of strength that they might feel comfortable with during an MDMA session. So treatment room is probably not, well, probably very different than any sort of other treatment rooms you've seen. It is going to be more similar to your living room than, you know, any sort of, like treatment setting that you might consider in a medical or a professional psychologist setting. So it's going to be, but it is going to have components that are similar, like privacy and quiet. And it's going to, it's 8 hours, right, with the participant. So it's essential that there's a degree of comfort. And so it's developed with a futon, bed, comfortable couch, and is aesthetically pleasing in as many ways as it can be. And also considering like the placement of therapist chairs to kind of not be so close, but also not so far away. And and also not be like right there together. And just creating a relaxed, comfortable atmosphere. When it comes to bringing up traumatic material or discussing traumatic material in prep sessions, it's neither encouraged or discouraged. But the participant will have to discuss their index trauma with independent raters and through that process. And all things might come up, and so it's okay whatever they're bringing into the prep sessions and desiring to talk about and share. The therapist will ask for permission to bring up their trauma during the MDMA sessions if it has not come up, which is rare for that to happen. Often it's the case that they are bringing it up naturally. When discussing the integration period in prep for the MDMA sessions, it's, this preparation really allows, or it's essential in helping provide a safe and grounded landing for the participant following the experimental session. Like really exploring all of these things, like can they have get groceries before? Will their place be clean? Considering arrangements for childcare. What would it be like, is there the option to take a day off of work rather than returning to work? Who could you contact or talk to? Like, are there things that you might consider writing it, or maybe they might use a journal and we might explore with them, like writing things down versus immediate sharing with too many people of their experience. And again, all of this allows for kind of like a safe and grounded landing following the MDMA sessions. And relaxation the day after the session is so important and helpful for the integration process. We'll briefly touch on music, but music is part of the experience, which helps support the emotional experience. But it's we are mindful of minimizing suggestion, which usually involves no lyrics, especially in the primary language of the participant. And the participant may even request periods of silence, which therapists are going to ensure that they're allowing to basically whatever the participant requires, and sometimes it might be relaxing or a little bit more active, but nothing is going to be too interruptive of a process, but it's more supporting that process. And so we're going to look at the MDMA sessions. At the beginning of the sessions, really to kind of create relaxing into the atmosphere, the participant is encouraged to put away like their items to really get comfortable. And vitals will be checked. There will be a urine pregnancy test and a urine toxicology screening. And a lot can come up for the participant prior to entering the space, as they're, so much they're thinking about before the MDMA session. So it's helpful to provide space to check in about those questions, concerns, or any recent thoughts and experiences. And so the logistics of the session will be reviewed, and we'll also review agreements such as their agreement to not leave the facility, having at least one therapist in the room at a time, the participant not harming themselves, others, or property. And a reminder that therapists will bring up trauma if it doesn't come up spontaneously. I do want to check in about time. How are we doing?
I think we were trying to wrap up a little bit around 8, maybe. So we can probably go over a little bit. I don't think if you guys are all right with sticking around for a little bit longer to field some questions.
Yes, I'll try to hurry at this point for you all. It's a lot of information. So at the beginning of the sessions, we're going to remind the participant that we're there for support, and also just a reminder to surrender the experience. And we offer the MDMA in a bowl, which is this offering reinforces the invitation versus direction, and the choice and agency are so important here because it's the participant's choice. But 15 minutes following the administration, they're encouraged to take some time inside, put on eye shades and headphones if they desire. But if there is silence ongoing, we'll check in after an hour. And at 90 minutes, we'll check vitals and explore the option for the supplemental half dose. Distressing feelings arise, and if they do, therapists will remind the participant of their presence and support through reassurance. And we're here with you. We'll encourage a curiosity of what's there, right, with that distress, reinforce breathing, and really bring a normalization of that discomfort as part of the experience. And that normalization can be powerful. And just a reminder that this is a natural part of moving through inner territory that they may not have fully faced or experienced. And looking at the integration sessions, so there's 3 90-minute integration sessions which follow each experimental sessions. And there's the first integration session immediately follows, or sorry, not immediately, but follows the following day of the MDMA session. And then that includes phone sessions where within the week after the MDMA sessions, the therapist will check in with the participant multiple times. And, integration is so critical in following these sessions with MDMA, as there's a lot that comes up for the participant. And the integration really allows like a weaving of that experience and those new insights into that they can bring it into their daily lives and continue to work through it. And so the therapists are going to be supporting them in that process. And that begins again the day after. And so this is the emotional processing is going to continue, right? They may bring these new insights and new ways of feeling and thinking into their daily lives. They might have challenges. And so the therapists are normalizing all of this, right? It's like there may be a full range of emotion that they're experiencing. And so the therapists communicate their support while also really encourage really being curious about that as well for the participant, and being with that and moving through it in the same ways that they might have during the session, or using those stress reduction strategies So again, the full range of emotion might arise. And we share that whatever comes up between the sessions, similar to in the MDMA session, is also part of their healing process. And so just to wrap things up, integration can be such a deep experience. There might be an urge to share, and participants often do share, but it's also powerful to hold on to the experience. And there's the potential that others might not connect or appreciate the depth or the magnitude of the participant's experience. So during the integration session, we'll explore avenues of expression, whether that's through journaling or art or meditation or yoga, or any avenue that could support integration and facilitate help facilitate the development of new coping skills, or the ability for them to move through any sort of positive or difficult emotions that they might be having. And really encouraging the participant to like allow themselves time to just take things easy and make sure that they have the opportunity to really make space for what follows their experience as well. And so, and again, the therapist will schedule multiple phone check-ins for the week following the experimental section. And sorry if that was really rushed, you all, but some further reading options. So on maps.org, we have the MDMA Therapy Treatment Manual, as well as the Investigator's Brochure. Some other reading suggestions: The Body Keeps a Score by Bessel van der Kolk, Trauma and Recovery by Judith Herman, and An Unspoken Voice, or Waking Tiger by Peter Levine, and Consciousness Medicine by Francois Pourcent. You can also find information on the MDMA therapy training program, which Mike and I went through, and it's a required training for anyone entering the current studies. And so it consists of an online course, training retreat, experiential learning, role play, and supervision. And with that, I will stop the share and open it up.
Awesome. Thank you both so much for those presentations. Super comprehensive, super informative. Really appreciate it. So just to explain the Q&A format for folks, what you can do is go to the participants tab and raise your hand. I believe that'll be a feature there, or function. So if you want to ask a question, raise your hand using the Zoom function to do that. And then Will or I will unmute you and let you know to ask your question. You can fire away. If you feel uncomfortable sharing, via your voice and video, feel free to just type it into the chat, and we can ask questions that way as well. So yeah, just raise your hand and we can call on you to ask your question. All right, we have one here from Connor Lewis, so I'll unmute you, and you can ask your question when you're ready.
Hello, Dr. Burke and Dr. McCowan. Thank you so much for presenting today. Dr. McCowan, based off how you were describing the therapy sessions, it sounds like a lot of the big breakthroughs come through sort of internal, almost hallucinogenic experiences with MDMA. So I was wondering if that assessment is correct, and if it is, have you or Dr. Burke thought about the therapeutic effects of other drugs, potentially like psilocybin, LSD, or ayahuasca?
So I just wanted to make sure was that or was there an attribution of the breakthroughs to the effects of the MDMA? That's what I heard in the question. So often the breakthroughs don't come through the medicine itself, right? It's not that which leads to the breakthrough. It's more a combination of elements of the supportive space and safe setting, as well as the presence with the therapist. It's a combination of things. It's the therapy, the safety, the alliance, as well as the decrease or the reduction in fear, right? And the increased capacity for individual to engage with potentially difficult material that they might have avoided or not engaged with in a safe way in the past, which is more likely to lead towards those breakthroughs versus the effects of the MDMA itself.
Yeah, so I think, so it's like kind of, in a lot of ways, it's like a mysterious process. Yeah, and you can't really predict like what direction something's going to take or like when the breakthrough is going to happen. I think with like all the different substances you mentioned, like the one kind of common thing is that, we're in like a kind of a, mind's in a temporary state where, you're not in like the typical thought patterns that we've, developed, the defenses and things that we've developed over years. So this kind of gives us this window where like that's interrupted and, you might see things in, in a different way. I think, in MDMA, the big difference there, I think, is the, reduction in fear so that, more of these traumatic memories are able to come up and kind of be processed. And it's, it's kind of narrative type memories, things that you remember. And it's also really kind of, a lot of things happen viscerally. And I think, the other ones you mentioned are like classic psychedelics, which are, obviously have their, differences. Can also be like really effective. They haven't, with depression and alcoholism, it seems like, there's, a lot of benefit there. And I think it's kind of a matter of, we'll see with more studies what might be, what might be effective for what. Ayahuasca is a classic psychedelic where you hear a lot of like, anecdotal evidence of it being helpful for people with PTSD. I don't know that it's been like rigorously studied enough that we can, that we can say that, but, a lot of potential, and it'd be, I think it's going to be interesting to see, what develops with these.
The next question here is from Alejandro, so I'll unmute you.
Hey, good evening. I'm a medical student down at LSU in New Orleans. I've gotten the chance to work as a night attendant on the MDMA, on the MAP study down here. And one of the things that the therapist said after the 8-hour session, experimental session with the patient, she says she's exhausted and she feels like she has to go home immediately. So Dr. McCowan, I was just kind of wondering, looking forward to the future, do you see this as something you could do every single day? Or like, how many of these could you do in a week? Like, could this be your entire practice?
Great question. I hear what your therapist was sharing, and that resonates. It feels very exhausting. At the same time, we take a lot of care and attention to not only creating the right conditions and space for the participant, but also for ourselves prior to these sessions. Rest is important. Making sure that we can decompress afterwards, huge. Even making space before and after, right? And so I certainly would want to do it every day, but I don't necessarily know if I would be able to. Probably 3 or 4 days. Or no, not in a 5-day week, 3 days, probably.
Yeah, you know, in Marcella, who trained us, who's been doing this for a long time, I remember during our training, she said she felt like 1 day a week was like the max for her. So yeah, I think one of those things that like varies person to person. And I did just want to echo with regard to that last question, that what Joseph said about, you know, the therapist role in the treatment is, you know, a really important part of it too. More than just taking like the MDMA and like things being cured, but, you know, developing with a therapist, working with a therapist and kind of processing things.
All right, so our next question will come from Azim in the audience. I will unmute you.
Hi, thank you both for those extremely detailed and very interesting presentations. One thing I was wondering is this sort of capacity for inner healing. You know, that sounds like a very sort of powerful modality. I'm just wondering, you know, are there certain patients, participants who maybe experience very early childhood trauma, who in some way that capacity itself has been eroded or is somehow not present, and if that's come up during the accumulated experiences with these therapy sessions, and how that's dealt with. So that's sort of my first question. Second question is maybe is sort of out of the realm of you guys' ability to answer, but I'm just sort of curious and kind of piggybacking on the previous question. You know, as this therapy, if it becomes approved, and hopefully it does, you know, how is the sort of rollout gonna happen, or what's envisioned there? Will people only is it, you know, sort of, is MDMA only going to be made available to therapists who have completed the sessions, and how will the sort of integrity of the therapy be upheld, you know, once this moves out of a clinical trial phase? Thank you.
Yeah, so to your first question, I would say I don't think it erodes it, but I think it might be more, you know, maybe more challenging to access it. You know, and I'm fairly new to the study. You know, people who have done more of the work kind of say that they feel like for complex trauma, it may be one of those things where it, you know, just takes more sessions. You know, and I think if you're interested in that topic, you know, internal family systems therapy kind of has a really interesting model and way of like framing that with the different parts, and then with what's underneath that. So if you're interested, that might be a good one to look into. And I don't know if Joseph or Cole want to address that or address your second question.
I'm just going to second what you shared, Mike. You know, not eroded in young people with complex trauma, but just might be more difficult to access for sure. And even second the suggestion with regards to IFS is a really great way to kind of explore that and build that, explore parts and kind of build their connection to those pieces.
Yeah, I think this treatment is not different from other modalities for working with trauma, and that more complex trauma is more complicated and more difficult to treat. Historically, you know, this will be my third trial with the MDMA for PTSD, and we've seen very complicated cases, and we've seen more direct, like clear single index trauma kinds of cases. From a therapy, and you know, we talked a little bit about therapy burnout and exhaustion, and you know, the emotional toll that it can take. Those more direct, straightforward ones feel a little better because when they get a lot better, they get back to like totally functional. And I thought that the more complicated cases maybe didn't respond as well, but actually the data shows they have a significant of a change in quality of life, change in CAP scores, but they still have trauma to work with. And so it seems like what we're seeing is with 2 or 3 treatments, complex and more simple traumas, not that any trauma is simple, but respond robustly. But the more complicated, the more treatment may be necessary. But the protocol only allows 3 treatments right now. And as far as the rollout, it's not 100% clear, but at least initially, yeah, people will have to have the certification in the MAPS therapist training program in order to administer, and it has to be done very similar to this protocol, at least initially. I think they're getting some sort of use exclusivity with their data that allows them to use MDMA exclusively for a period of time. And after that, it'll be like anything else where the patent, it's not a patent, but it's some other sort of medical legal thing that is beyond my juris doctorate level. But it's something, it will be for at least the first 5 to 6 years exclusive to people who get the MAPS training. And that's, that's a real internal sort of conundrum. Like, how do we control the quality and also promote the access? If you have suggestions, MAPS is very responsive and open to suggestions.
All right, thank you. Our next question, Joel Lopez.
All right, thank you. Thank you, Dr. McCowan and Dr. Burke. Yeah, just when you were talking about kind of the like the somatic sensing portion of it, I guess kind of in the process of it, is it beneficial to have them expand on, so say they feel it in their abdomen or in their chest and like difficulty breathing or any combination of that? Is it advantageous to kind of ask in the moment versus in the integration session, and kind of what are benefits of opening up that like line of question in either moment?
You mean the ask to explore it and kind of?
Yeah.
Yeah. So during the medicine sessions, if they're sharing that something is there, something that they're feeling, there is a kind of like a encouragement to kind of be curious about that and explore that, and which sometimes is enough for them to kind of just be with it. Sometimes that elicits like more sharing about what's there, and so really we'll work with whatever comes up there. Does that answer the question?
Yes. Yeah, mainly.
Good to see you, Joel. Also.
Yeah, good to see you too.
Yeah, and I think a lot of it too, at the same time, being really careful to not, on our part, like interrupt the process and just kind of let things, let things, kind of like run their course, because there is, some type of like synergy with the medicine and the inner healing intelligence, and it'll kind of do its thing. But if, especially if they're having like a difficult time with things, that's when you might get into different ways of helping them kind of stay present with the situation. And then, depending on like what comes up, yeah, maybe the time to kind of, engage with them and like help them process that material.
Very interesting. Thank you, guys.
I had a quick follow-up question. Just wanted to interject. I thought it was interesting you mentioned or talked about who the participant should share the experience with afterwards. And maybe there are certain people in their life they shouldn't really talk to about the experience. And I was just wondering like how you guided them on who they should talk to about it and who they shouldn't, and what some of the risks are of telling someone who might not be accepting.
Yeah, so it's not necessarily like like a determination isn't made in that moment of, don't tell this person or don't tell that person. But during the integration session, there's kind of, just a communication around it's sometimes normal to desire to share this experience, right? And and that's okay. At the same time, there's like a caution provided that because sometimes when people do share and they have a really powerful and deep experience, it's not always, they don't always feel seen or heard by another. And so it's really kind of, it's not necessarily saying that that will happen, but that there's the potential for that to happen. So there isn't a selection of who to tell and who not to tell. It's just a general kind of communication around. It's okay to also hold on to the experience as well as share it. That's ultimately what is communicated. It's powerful to hold on to it. It's also powerful to share it. At the same time, when you share, it might not be completely heard, or,
All right, next question in the chat is going to be from Halsey, though. I'll just say on timing, I think maybe we have time for a couple more questions. So if you do want to ask a question, make sure to raise your hand and we'll hopefully get to you soon.
Glad I got in here. Thank you guys for a really informative and comprehensive talk. I had a couple questions, I guess, about some of the safety concerns you guys discussed. Specifically, kind of wondering, you listed some of the exclusion criteria that have existed for the trials so far, in terms of like ruling out prior strokes, cardiac histories. Just wondering, in thinking about, in a sort of a post-FDA approval world, do you think that those same restrictions would apply, or kind of who do you think would be, in your thinking, actually restricted from such treatment? And then secondarily, I may have misheard, but I thought there was a mention of like some harm that came to people within some of the phase 2 trials with the low dose arm. I was just wondering if you'd mind expanding on that.
Sure. So I could give an answer. I don't know if Cole might be able to give you a little bit more. I'd be interested to actually hear what Cole thinks about, going forward, who, may or may not be good candidates. Yeah.
I missed the first part of the question, but I heard the second part. Can you repeat real quick just the first question?
Sure. The first question was sort of, in thinking of a post FDA approval world, what medical exclusions do you think will carry forward into that time, in terms of, cardiac history, stroke history, et cetera?
Right. Yeah, I think those are primary ones. Also, like primary psychotic disorders in psychiatry, some traumatic brain injury, like seizure risk things. Disorders that lower seizure risk because it's a psychostimulant could put somebody at risk. And then, cardiovascular is probably the largest medical category for consideration. And then in psychiatry, bipolar and schizophrenia are excluded at this point. For the phase 2 trial where low dose was found to be actually harmful, that was in primarily, I think it was military, fire, and police, that study. And they used 30 milligram as a proposed placebo. That was a decision they made instead of nocebo or niacin or something like that. And they found that the 30 milligrams was just stimulating enough to make the anxiety worse, but not to provide any sort of support. And so people, and this is pretty universal, that people come into their first session pretty anxious. Like they've spent a month going through the screening process. They've oftentimes tapered off of serotonergic medications. They've been talking about addressing their trauma in this big day, and today's that big day. And so their anxiety is already at like a maximum level going into that first session pretty often. And the to 120 milligram dose seems to cause that oxytocin, warm, safe feeling, and 30 milligrams seems to just provide the stimulation.
Fascinating. Thank you.
All right, next question will be from Jordan.
Hey guys, thanks so much for the talk. Over the course of the summer, we had the pleasure of hosting Monica Williams and Sarah Reed. We've been doing some of this work as well. And something that we were discussing and it's been on my mind is the cultural adaptation of this therapy. And just wondering, in your experience over on the West Coast, what, if any, ways do you either have you put in practice or would you envision from your experience doing cultural adaptation for different racial and ethnic groups from sort of the base protocol? Any thoughts on that?
Anybody?
Yeah, so, I mean, certainly, you know, I think there's tons of attention that needs to be brought when there is, or cultural considerations towards when there is either a different cultural background of the therapist and the participant, right? So we talked about the prep session. So even providing the space and the, sometimes even naming that there, you know, that there are these cultural differences and having and allowing that into the space and into the conversation and seeing what is, if there are anything, if there's anything there that might present for the participant as, you know, anything that they want to discuss or talk about. And in the prep sessions, that is really hugely important in allowing the participant to know that they can share in the space anything related to their cultural trauma or racial trauma or their experiences that might, you know, or I guess what I'll say is sometimes like a person of color might come into a study and might not feel comfortable sharing certain things with like a white therapists or a therapist of a different background. And it's really, attention is paid towards making sure that the participant knows that it's a comfortable space for that, even if they don't match the same cultural background as the therapist.
And it's an identified problem in the psychedelic community at large, that it's historically been a predominantly white kind of scene. That's no different in the academic psychedelic community. And so some efforts have been made, you know, to explore what are those, what is that about? There's been some financial incentives given to try to attract more therapists of color, to have more therapists of color involved in providing the treatment. And then in the actual preparatory sessions, we do ask extensively about racial trauma or ethnic trauma. So that's how we try to invite the conversation. And you know, within recruitment, it's something that we are mindful of. We've had a distribution similar to the American population with regard to race in the phase 2 studies that were done, but we still have a long ways to go for sure with regard to having equal representation in the therapist pool.
And I mean, we, you know, along with that, like considering, you know, one's cultural background with the selection of music, as well as just, I mean, bringing a beginner's mind to experience around cultural issues as well, right? Like we may not know what another person outside of our cultural awareness might be experiencing with regards to like multiplicity of the psyche or somatic manifestations or any of these things. So it's, you know, just a curiosity and like a welcoming of, just really allowing a person to bring themselves to the session, as well as like even during integration, recognizing, it might not be meditation, it might not be yoga that they're connecting with, it might be something else completely that I might not be familiar with, or Mike might not be familiar with. But so we're really attending to and listening to the participant and exploring with them what it might be for them to help facilitate that process.
Thanks, guys.
Welcome.
I know we're a little bit over. It's 8:16. Might try to do one last question. Does that sound all right to everyone? All right, so we've got one from Aaron Wolfgang.
Hey guys, yeah, thanks again for the great presentation. So I've done the training a year or so ago with Jordan there, so hey Jordan. But I'm also in the military, and for those of us in the military, doing Part C would probably be problematic just from a legal standpoint, and since it's a Schedule I drug. So I'm wondering, in your guys' experience that have gone through Part C and of course the whole training, how critical would you say is it to be able to go through the experiential portion, and depending on that, what would you say are some important lessons to take from that experience, and how that's informed how you I guess interact in these sessions?
Well, for me, I'm not sure what Part C is, but based on the question, I'm guessing is having an opportunity to have a personal experience, which is open to therapists in the training program. There's a separate study that's been approved by the DEA for a healthy adults study that provides an opportunity for therapists to have their own MDMA experience sitting with two therapists. And they go through the same physical and health background. Mine was actually a holotropic breath work experience, which is a non-substance induced, non-ordinary state of consciousness. So that's a potential opportunity for people who, for one reason or another, can't have an MDMA experience. I think it's likely very different from the MDMA experience, the holotropic breathwork experience, but it is an experience, and I think it was almost as important to be sitting with somebody who's having a non-ordinary experience. I think that was probably just as helpful in practicing holding space for, for somebody who is having a very different experience. Holding space, creating a safe container, being supportive, sitting with silence, all of those things were really helpful. I don't think that you have to have it in order to be a good therapist at this, though. I think that's the MAPS team is predominantly from the psychedelic community and not primarily clinicians. And so I think they have from them, there's more of a sense of the importance of that. I'm not saying it's not important, but like, you're in the military, I worked in the VA. I think it would be great if I was also a veteran, but I don't think I have to have been a veteran to be of any use to a veteran. I kind of think of it like that. Like, if you haven't had an MDMA experience, I don't think you're useless to someone who's having one by any means.
All right. Thank you, Dr. Burke and McCowan and Marta, for being here. It's been wonderful having you. I hope everyone has really enjoyed the discussion. It's been very informative. I've learned a lot. And maybe Rob, I'll let you sign us out if you have any final words to say.
No, again, just to reiterate what you said, thank you to the presenters for coming here and sharing your time and energy with us. Super appreciative. And thank you to the folks who showed up and paying attention, and to those who asked questions, thanks for contributing to the conversation and the experience of everyone. Super appreciate it. We don't have, as far as I know, an event lined up or on the schedule right now, but we'll probably be having one, of course, sometime in the coming month or two. So keep checking your inbox, and hopefully we'll be pinging you soon enough about upcoming events. So yeah, just once again, thanks again to Dr. Marta, Dr. McCowan, and Dr. Burke for sharing your time and energy. Really appreciate it, and hope you all have a good rest of your day.
Thank you all so much.
Yeah, thank you guys.
Thank you. Thank you.